Let's jump right into this explainer and cut straight through the medical noise. We're hunting for those life-saving diagnostic signals you absolutely need for the boards and, more importantly, for the wards. We're talking pediatric clinical heuristics. These are the crucial tipping points separating a harmless, self-limiting sniffle from a literal life-threatening emergency. You know, in pediatrics, your patients often can't just tell you what's wrong, so it's on us. We have to be experts at picking up on those subtle, silent signals buried under a mountain of clinical noise.
I mean, think about this. Why could a simple wooden tongue depressor be fatal in a child with stridor? It sounds like a rookie mistake, right? But doing a routine throat exam on the wrong patient can actually trigger an immediate, life-threatening airway closure. When a kid rolls into the ED with noisy breathing, your gut reflex is probably, let me look in their throat. But as we'll see today, reacting blindly to the noise of respiratory distress without finding the true signal first, that can be a fatal error.
So let's get into Section 1, Decoding Pediatric Airway Stridor. When you're facing pediatric stridor, your very first move is to audit the timeline and positional physics. We're looking at the classic 50-50 dilemma. Is it chronic, like laryngomalacia, a congenital issue where the stridor starts at around 2 weeks of age, is purely inspiratory and literally shifts with gravity? It gets worse when they're flat on their back and better when they're on their stomach. Or are we dealing with an acute infection like what's mapped out right here? This is the diagnostic matrix between croup and epiglottitis. Croup is viral, usually parent influenza. It hits with a few days of a runny nose, low fever, and that classic seal-like barking cough. The stridor doesn't care what position the kid is in. Epiglottitis, on the other hand, is a whole different beast. It comes on fast, over just hours. The kid looks incredibly toxic, has a spiking fever, a muffled hot potato voice, and they'll be in the tripod position, leaning forward, neck out, just fighting for every single breath.
Now check out this classic steeple sign showing subglottic narrowing. It's a huge radiographic signal for croup. You can clearly see how the airway tapers symmetrically, just like a church steeple. But let's do a real signal versus audit right now. This is a classic board signal, sure, but it is only present in about 50% of cases. Literally half. If the X-ray doesn't show it, that is just noise. Let me repeat that. A negative steeple sign absolutely does not rule out croup. And for laryngomalacia, the true signal isn't an X-ray at all. It's the dynamic collapse you see on a flexible laryngoscopy.
Which brings us right back to that opening question. If you suspect epiglottitis because you caught that tripod position in the drooling, do not, under any circumstances, use a tongue depressor. The airway has to be secured before you can make a definitive diagnosis. The only correct execution here is immediate transport to the OR for controlled intubation by anesthesia or an ENT. If you force a physical exam in the ED, you can induce laryngospasm and completely close off whatever tiny airway they have left.
But okay, what if we get thrown a curveball? What if the child has 0 fever and suddenly starts wheezing at a birthday party? There's no viral prodrome, no days of a runny nose, nothing. Just a sudden, terrifying onset of severe coughing and dyspnea right in the middle of playtime.
You have to immediately suspect foreign body aspiration. The object usually lodges in the right main bronchus, simply because it branches off the trachea at a less sharp angle than the left side. And this creates a treacherous ball valve effect. Air gets in, but it can't get out. That causes unilateral hyperinflation on the exact side of the foreign body, and you'll often see the mediastinum pushed over to the opposite side. Immediate removal via bronchoscopy is your required next step. No waiting around.
Moving on to Section 2, the abdominal midline barrier.
Let's look at how strict anatomical boundaries literally dictate the diagnosis of pediatric renal region masses. The tipping point here is the midline barrier. Wilms tumor, or nephroblastoma, typically stays on one side, while neuroblastoma aggressively crosses that midline. Wilms is usually a smooth, firm mass that you stumble upon incidentally in a totally healthy-appearing 2 to 5-year-old. But here's a crucial diagnostic signal: microscopic hematuria. Don't make the dumb mistake of not checking the urine. Also, always evaluate for Wagner syndrome to catch things like aniridia or genitourinary anomalies. Now, neuroblastoma, that arises from the sympathetic nervous chain. It's irregular, it's nodular, and it does not respect the midline at all. These kids look systemically ill, often with bone pain and signs of excess catecholamines.
Neuroblastoma also throws off this bizarre, truly pathognomonic signal known as opsoclonus myoclonus syndrome. You'll often hear it called dancing eyes and dancing feet. It's a wildly distinct paraneoplastic phenomenon. What you're looking for are rapid, chaotic, multidirectional eye saccades with no pause between them, paired right alongside sudden arrhythmic jerking of the arms and legs. So, imagine a board-style scenario. A 2-year-old presents with truncal ataxia,
those chaotic eye saccades, and a right upper quadrant mass. Boom! That combination strongly points to a neuroendocrine tumor of the sympathetic nervous system. It's a perfect example of how we synthesize systemic neurologic signs with hard physical anatomy to isolate the exact diagnosis, cutting right through the noise of general childhood irritability.
All right, let's wrap up with Section 3, Neonatal Infection Executional Pearls.
Let's look at the xanthomechanics mechanics here. Notice the exact temporal tipping point. For roseola, caused by human herpes virus 6, the rash only appears after a soaring high fever, often over 104 degrees, has completely broken. And honestly, the child usually looks surprisingly well despite that crazy fever. But the exact moment the fever resolves, that's when the rash erupts, and it's also when they are at the highest risk for febrile seizures. This is a total diagnostic dividing line, from measles, where the fever and rash happen at the exact same time, and the patient looks absolutely miserable with cough, coryza, and conjunctivitis. And beyond timelines, we always have to audit for severity. A lacy slapped cheek rash, that's stable parvovirus B19. A rough sandpaper rash, you need a rapid strep test for scarlet fever. But a rapidly spreading petechial or purpuric rash, that is a meningococcemia critical emergency. Now here is a massive execution gap on the boards and the wards. When dealing with an infant under 28 days old, the fact that they appear well is completely irrelevant. Do not let it fool you. Because of their immature immune systems, any neonate with a fever of 100.4 Fahrenheit or higher mandates a full septic workup, blood cultures, UA, and a mandatory lumbar puncture. Plus, neonates rarely show classic meningeal signs. You cannot rely on a stiff neck to diagnose meningitis in an infant. You have to look for subtle shifts, lethargy, poor tone, a bulging fontanelle, or even hypothermia. Oh, and if you see unexplained apnea in a young infant, you must immediately consider RSV bronchiolitis. Older kids get respiratory distress, but young infants, apnea is often their very first presenting sign. And if you're treating that septic neonate after your full workup, never administer ceftriaxone. Never. It's a classic, dangerous execution gap. Ceftriaxone displaces bilirubin from albumin, which leads to catastrophic biliary sludging and a massively high risk of carnicterus. Instead, your immediate empiric coverage should be ampicillin and gentamicin or cefotaxime to safely cover those typical neonatal pathogens without the sludging risk.
So as you head back to the wards, I have a challenge for you. Look past the overwhelming noise and hunt for the specific, irrefutable signals that define true clinical mastery. Are you letting a negative steeple sign rule out croup? Are you trusting a well-appearing 2-week-old who happens to have a fever? The master clinician knows exactly where these tipping points are. When the stakes are literally life and death, are you reacting to the clinical noise or acting on the signal?